The conductive system of the heart is how the heart is creating these spontaneous releases of action potentials and how the heart is able to beat on its own. It consists of the sinus node or the SA node, sinoatrial node, the internodal pathways, the AV node or atrioventricular node, the bundle of His or AV bundle with your right and left bundle branches leading to your Purkinje fibers on the end. The SA node or sinoatrial node gets self-excited and is the initiator of the rhythmical impulse that spreads throughout the internodal pathways in the right atria and the left atria until it reaches the AV node, where the pulse is delayed at the AV node and bundle, and then it's transferred to the ventricles via Purkinje fibers after it's moved through right and left bundle branches. So in more detail, the sinoatrial node is our pacemaker. It's going to spontaneously depolarize at the rate of 70 to 80 beats per minute. We then have internodal pathways that are located here. They are all actually named. We have an anterior Bachmann's bundle, middle Wenckebach tract, and posterior Thorel's tract. I would not even worry about knowing these names at all. I would just know them as the internodal pathways. These tracts conduct the impulse through the atrial muscle to the AV node here. At the AV node, the impulse is delayed by not even zero point 0.1 seconds, but this allows for the atria to do atrial systole or atrial contraction prior to ventricular contraction. Then after our AV node, we have our AV bundle or the bundle of His, which conducts the impulse from the AV node into the ventricular septum. And then we have in the ventricular septum a right and a left bundle branch, which travel along the intraventricular septum and then fray out into Purkinje fibers that rapidly distribute the impulse throughout the whole ventricular myocardium. And the myocardium will contract then from the apex to the base, which means that it's going to eject blood upwards towards the great vessels. The SA node, by definition, is a small flat strip of cardiac muscle cells that have no contractile muscle filaments. They are very much just flat cells of conductile or conductive tissue. They're in the upper posterior lateral wall of the right atrium, and they're below and lateral to the opening of the superior vena cava. And they are contacting atrial fibers directly, and they're controlling the beat of the entire heart. So, what do these action potentials look like? The action potential we talked about before was the ventricular action potential, and it's this green one here. It looks a lot different than, as you can see, than these smaller, more kind of almost looks like casual lean of the SA node fiber action potential. So this SA node fiber has this slow influx of sodium, which is pre-potential. Once it reaches threshold, then we see a rapid influx of calcium, an outflow of potassium repolarization, and then this slow influx of sodium again. So this would be kind of your pattern of the action potentials of your SA node. They start less negative, the sodium and calcium ions are leaky, and there's fast sodium channels that are blocked from opening due to the higher resting membrane potential. So these fast sodium channels that cause this major rise in our ventricular muscle fiber are unable to open in our SA node action potential. So the process of self-excitation is just the process of automatic rhythmicity, discharge, and contraction. A higher concentration of sodium in the extracellular fluid encourages sodium to leak naturally inside of the cell. It does this through what we call a funny channel. These are funny sodium channels and calcium channels, but we'll talk about funny sodium channels first. Between the heartbeats, we have an influx of sodium ions that leads to the slow rise in resting membrane potential. And once resting membrane potential reaches negative 40 millivolts, our L-type or slow calcium channels open, or I guess you could say L-type fast calcium channels open, and that's what triggers an action potential. So really, it's the leakiness of sodium and calcium that causes this inward self-excitation. Once this self-excitation happens here and it's traveled from the SA node to this AV node here, we'll see that this is where things are delayed. And this is also located in the atrium, the right atrium, just more in the posterior wall behind the tricuspid valve. And this allows for atrial contraction to occur. And it happens because there's less gap junctions between cells in this space. And this also is what slows our transmission of the action potential due from the atria to the ventricles, and there's just less ions that can move. The AV node, it has slows conduction down very small. It creates a small little delay. Once we get through the AV node, though, things are fast in the Purkinje fibers. They're the opposite. They're the largest. They're larger even than ventricular muscle fibers. They transmit the action potential way faster. They're located just beneath the endocardium and they spread over the whole ventricle, eventually becoming just one with muscle fibers. And they have really fast conduction speeds simultaneous to ventricular contraction. And this allows for the syncytium, the instantaneous contraction of cardiac muscle cells. They have way more gap junctions, so they have way more permeability in their intercalated discs. It is a one-way pathway here. The signal in normal healthy tissue is unable to travel backwards, which prevents re-entry of cardiac impulses or arrhythmias in normal states. And the signal is forced to go from SA to AV to Purkinje, and the atria and ventricles are conveniently separated by an insulating fibrous barrier, except for at the AV bundle. This is where we're able to get the signal to cross through. But this allows for control of our conduction pathway. So again, why does conduction only go one way? It's because we have a fibrous skeleton of the heart, the annulus fibrosus, which you can see, I think, up ahead. I believe I have, in our anatomy lecture, I have a picture. But this electrically insulates from the atria from the ventricles. It's made of dense, really connective tissue that doesn't conduct electrical impulses. And therefore, the AV node and bundle of His are the only way through. This helps us have atrial arrhythmias being transmitted to the ventricles, so a flutter doesn't get transmitted down below because the AV node is kind of a gatekeeper, limiting the rate of ventricular stimulation. In AFib, though, the AV node filters some of those erratic apical impulses, which gives you an irregular but a survivable ventricular rate. If this fails, such as accessory pathways and Wolff-Parkinson-White syndrome can bypass the AV node, this can allow for premature ventricular excitation, which is a risk of really dangerous tachyarrhythmias. And we oftentimes see this on EKG as a delta wave in a really short PR interval. As I mentioned, the SA node is the pacemaker, so it sets the pace of the heart because the SA node is faster at discharging in action potential than the AV node or Purkinje fibers. It sets the pace at about 70 to 80 beats per minute. The AV node itself would set the heart rate at about 60 to or 40 to 60, and Purkinje fibers 15 to 40. If anything else besides the SA node sets the pace of the heart, we call this an ectopic pacemaker. We'll stop here. When we come back, we'll talk about the autonomic nervous system and its relationship to the heart.